And good afternoon, everybody. Just make sure that I'm not on mute. Everyone can hear me, so nod your heads. As Kerry mentioned, I have the pleasure in providing the background about how this evaluation has come about and about all the partnership work that's been occurring. On the 22nd of January 2020, the Queensland Government announced that COVID-19 was a significant public health event, and I think it's safe to say that our lives have changed considerably ever since. The three health services of Metro South Health via the Health Equity and Access Unit, Brisbane South PHN via the Multicultural Health Team, and the MARTA Refugee Health Network of Queensland via the MARTA, quickly established a relationship and a partnership to make sure that we could disseminate critical health information and be ready to respond to community health needs. At the same time, we know that community organisations such as the settlement services were also making sure that people were receiving the most appropriate information that was available. But while we were doing that, we were certainly hearing around some of the gaps for information in easily understood forms. And we also were hearing that people were looking for information, but potentially accessing them through overseas or through social media, which might not have been the most reputable sources. So given the enormity of the task at hand, it became evident that we needed to have a coordinated approach. We needed to pool all of our resources. We needed to utilise all of our different skills and certainly our different relationships and partnerships that we had across communities and stakeholders. At the beginning of the pandemic, it was clear that there was a real absence of information around COVID-19 and public health directives that was in accessible formats. And it was particularly challenging for people who did not speak English or who had low health literacy or low literacy to really be able to access information in an easily understood way. We also knew that information was moving really quite quickly. So those traditional, can you still see me?
I can see you, Brooke, no problem.
Oh, okay, sorry. My device is completely moving and starting. So if you can still hear and see, I'll keep going. We knew that translated information at times just couldn't keep up with what was being happening, and there were many languages that weren't going to be able to access information in language at all. So in the early stages of our health partnership, we would take public health messages, we put them into simple English, and we would disseminate them through audio files or written files. We would work with our partners to deliver information to community leaders or community members via education. And that's where the collaboration and partnership really took off. So we formed a collaborative with Access Community Services, with Multicultural Australia, with QPAST, with QUAC and with Red Cross, and collectively we worked to facilitate access to information. The fact that Multicultural Australia and QPAST and Access had pre-existing community leaders forums that were able to be stood up and respond to COVID-19, where Dr. Young herself could come and present and have a two-way process, really demonstrated the value of having established pathways for engagement. As well as valuing trust, the collaborative identified 4 key principles to work by: collaboration, equity. This project and the work that we were doing certainly wasn't about serving everybody. It was working with those most at need. Community development and capacity building. And the last 2 principles were the critical bits of this work that I think are potentially more novel than previous traditional disaster responses. So the community development and capacity building were clearly demonstrated in the work that QUAC had undertaken. So QUAC had approached Metro South Health to say that they had a comprehensive COVID response plan for the community, but just needed some health information, and we partnered with them, and they would take simplified messages, pass them on to the community, put them in language, put them in audio files, and put them through traditional ways that community would access them, such as Facebook, WhatsApp, QUAC radio. Now, this demonstrated the fact that community is the best place to develop solutions and responses to meet their needs, and that many communities have highly developed communication channels that could be rapidly deployed and it allowed messages to be disseminated to community members by people they trusted. The same approach was undertaken by the G11 and many other community members who provided culturally nuanced messages and shared information through community preferred channels such as WhatsApp groups and social media. In June 2020, the 3 health services, with the support of the partners, commissioned the Australian Centre for Health Services Innovation, OSHI, from QUT, to evaluate our approach. And we wanted to know if what we were doing was effective. We wanted to know if it was reaching people and if it was meeting community need. But we also wanted to get some evidence around best practice so that we wanted to inform policy, and in the event of future disasters, such as floods or fires or pandemics, we would have something there already that people could use. So we didn't have to start from the very beginning around how you would do an approach with CALD communities. So a few things have changed since last year. Alongside commissioning the QT evaluation, the Department of Health through the Social Policy and Legislation branch provided some funding to do this work, and it's resulted in the CALD engagement project and having 2 part-time staff members who've really been able to take this work to the next level. And the Department of Health also now is doing the leading role around simplifying COVID messages. So before I hand back to the speakers, I just want to say a couple of things, which is around, whilst we're today here celebrating all of the work that's been done, I just want to take a particular moment to acknowledge the community leaders and the community members and community champions who, throughout this pandemic, have certainly gone above and beyond to keep the community safe, and acknowledge that without those people, that none of this work would be possible. Thank you. Hopefully I'm still live.
You are, Brooke. Thank you so much.
I can't.
And now you're muted. As is everyone else, I just want to acknowledge we're all muted just so that we can really hear what the speakers are saying. But if you have any questions or comments, please pop them into chat. We may have some time at the end for questions, but please, if you've got questions, pop them into chat now. And I just got muted. The next person I'm going to introduce, I'm not going to say needs no introduction, but but is a very familiar face to all of us, and really importantly for us as a part of this collaborative, has been a very familiar face for the communities that we work with. And our own Chief Health Officer, Dr. Jeanette Young, who realised very early on the importance of engaging with communities, hearing their questions and speaking directly to them. So Dr. Young, please join us and just share a little bit from you, please.
There we are, I've unmuted. It's lovely to see so many familiar faces. It's been fantastic, and I really think it's made an enormous difference. One day, could we please get together in person again so that I can really see people? It's not the same seeing people on a screen, but it's better than nothing, absolutely better than nothing, and is better than phone calls, so that's a good thing. So thank you very much to the Mater Refugee Health Network for your invitation to speak with people today, and to have the absolute joy of being involved in discussing this report. I mean, it shows that people genuinely want to look at what works, what doesn't work, what we can do going forward. So first, I'd like to acknowledge the traditional custodians of the land upon which I'm sitting here in my office, the Turrbal and Yagara people, and those elders in all of your communities, and if there are any amongst you today. So it's been fantastic, but we do have to do a bit of work about vaccination in those communities. They've done so well to date. They've just got to do the last bit so we don't fall over at the last hurdle, and the same with all of you and what you're doing. That chance I had to go down to Logan with the Premier and meet in person with a few of you was fantastic when we were opening up that vaccination centre there. So thank you. Your efforts over the last 18 months, it's scary to think we've been doing this for 18 months now and we're not really at the end yet. was pretty worrying. But anyway, your involvement and what you've achieved over those 18 months is just fantastic. And I'll just point out that one of the reasons I said to the Commonwealth I'd be really happy to work with the Commonwealth about bringing as many people from Afghanistan as we could possibly do was because I had so much confidence in your groups and what you do and how you can manage people coming in from different communities. And that piece of work was just so critical, what we did to bring those people here into Brisbane. And then I know you'll help as they resettle either in Queensland or moving on to other communities in Australia. So thank you yet again for what you did with that. So every single time I get out there, as you said, I'm seen by people. I've always worried about whether people understand what I'm saying, because there are people out there who have so much different understanding. It's not just language, it's intent behind language, it's meaning. And because of the work you've done in taking the messages right from the start, and we've got better and better at it, and this report will help us get even better, knowing that you've been out there from the start helping us to translate and even more importantly get the messages out to your communities in ways that your communities could understand them, because every community is different. So thank you for that. And for the large number of you, it's just been astounding, and you've just come every step along the way. So some of the things that my team here, after going in great detail through the report with me, said that the things that they'd picked up, but I'm sure you're going to discuss what you think is in the report and what we need to pick up going forward. The things that you'll hear in more detail that I've picked up is that first, there is that continuing real need for more diverse language translations of key messages, and that when they're translated, they have to be understandable. So not just a Google translator, it's got to be real translation so that the meaning's there behind it. It's not just the words, it's the meaning. That they need to be created and shared early and in a whole range of different formats. They need to be disseminated more widely than we've done to date, and there needs to be more engagement of community leaders like yourself and members of communities. So that was the key learnings that we've picked up here, but it'll be great to hear what you've picked up from the report. So I'm embarrassed to say, my team has said that I didn't know all this, I'd be a bit horrified, that our first translations took weeks and weeks to be finalised and posted up on our website. Yeah, I can see some nods. I'm glad we've got a bit better. We've now got to 24 hours, but I hope it's useful information. And that also we must consider the channels that we're using to disseminate those messages. Just putting up on a website is not good enough. We've got to do a lot more than that for how to reach communities. So we did realise that. So November last year, we did provide that little bit of funding for the engagement project, recognising the criticality of you as a key partner. And so that was really important. And that's built your capacity to expand your engagement with your own communities, and also to tell us what we need to do to better respond. So I know that a lot of you have taken the messages and made your own audio messages and distributed them through your own channels, and that you've taken them through Facebook, through WhatsApp, through text messaging and so forth. And hopefully that little bit of money, it wasn't a lot, hopefully that supported you to enable you to do it. So you've just been the absolute backbone to it all. So the key really is to understand how we can do this better, because in some ways I think we're coming to the most critical part of the pandemic. We've sort of managed to date through a whole lot of work involving you and others to keep this virus out of Queensland, but it's coming in. We're just getting incursions every single day now. We're managing to stamp them out, but eventually it'll become overwhelming and we won't be able to stamp them out. Hopefully we'll have enough vaccination across our community so that it's a controllable situation, because we can see what's happened in New South Wales. They're sitting around 12, 13, 1,400 cases a day with around that 7-9 deaths every single day, and with an awful lot of work they're suppressing it to that level. But it's easy to see that it could rapidly escalate from that level, except that they're getting their community vaccinated at the fastest rate in the world. I mean, what they're achieving down there is astronomical, because they need to, because they're right in the midst of their wave. Similarly, Victoria, we're seeing the numbers growing every single day. ACT is keeping them under control. New Zealand's keeping them under control. But eventually it'll be here with us in Queensland. I hope and pray that it won't be till we're 80% vaccinated, but there's every likelihood it will be. So the next set of messaging is what people can do to protect themselves as we see these case numbers ramp up. The first message, of course, is vaccination. That's absolutely critical. And from today, our 12-year-olds and older can be vaccinated. And it's really, really important. We're seeing more severe disease in younger people. It's really important they get vaccinated. So it's 12 and older need to be vaccinated. And we've got more and more and more channels for that to occur. So in our mass vaccination clinics that I know you're helping us with, and we're going to be opening them up very shortly, more broadly to walk-in arrangements, so that'll be easier for people. Then there's our pharmacies that are very shortly going to get large amounts of Moderna, which is a vaccine very, very similar to Pfizer, but it's a little bit easier to give, which is why the pharmacies are getting it in preference to Pfizer. Some will get Pfizer as well. Then our GPs are getting much bigger doses of Pfizer that they can give, as well as AstraZeneca. So we're going to have so much vaccine over the next few weeks. We will have enormous quantities of vaccine. So every single Queenslander, 12 years of age or older, should be able to get vaccinated. And it won't be long. And people who are 60 years of age or older, for those last remaining hesitant older people who don't want to, for whatever reason, get AstraZeneca, they'll soon be able to access Pfizer or Moderna. So everyone will have that choice and they'll be able to get it. So please keep your community engaged. Tell them to not give up yet. Soon there'll be plenty of vaccine, and hopefully every single 12-year-old plus will be able to have accessed a vaccine by the end of October. That's the aim. So we've got another 7 weeks to go that we have to hold this virus at bay. So if we can keep doing that work with our communities about wearing masks, we know they're really effective, about maintaining that bit of distance from people, not the time to hug and, friends rather than people in your own household. Just keep that little bit of distance for a bit longer. And of course, stay home if you're sick and get tested. If we can just keep that message going, and get everyone vaccinated. That's critical. So if we can do all that. So really, I think that was what I was saying. Yep, that was what I've been asked by my team to share with you. But essentially, it's really about, thank you very, very much for what you're doing. Keep going, as I know you will. We've just got to beat this virus until we're all vaccinated. And yes, the governments, Commonwealth and state, have set those targets for us of 70 and 80%. Let's set an internal target of 95%. And that'll really keep our community safe, because until we can get our littler ones under 12 vaccinated, even a target of 80% really means it's close to 60% or so of our total population. So it won't stop the spread at that level. That won't give us herd immunity. It'll give us protection. And we know that it's older people who are the most vulnerable. So really, let's try and get nearly everyone vaccinated who can be. And then we'll see where we go with kids. So all of those trials are happening at the moment. So thank you very much. I don't know if there was time for any questions or whether you wanted me to do anything else.
Are you going to be sticking around with us, Dr. Young?
Unfortunately not. We're still sort of in the midst of dealing with an outbreak at the moment, so I'll have to leave you, but always happy if you want to send through any questions that come through the process going through the rest of your meeting, or I do have a little bit of time now if there's anything I can assist with.
Look, I mean, it would be great if people have questions to pop them into chat, and we would be really, it would be wonderful to be able to send them on to you. And when we appreciate so much the time that you've given us, because we know, particularly at the moment, there's a whole lot of holding things at bay, and there's a whole lot of work that you're doing to make that happen. And look, thank you so much again for sharing that leadership that you've shown in really engaging with cultural communities. And that really goes to the heart of what this piece of evaluation is about, and the work that so many of us are doing in this space is about, is like that incredible engagement of recognising communities and community leaders as our critical partners in this work. Thank you so much, Dr. Young. I can see some applause happening in people's.
Well, I'd like to applaud all of you, really and truly, and please send through any questions and I'll make sure I manage those. But most importantly, send through if you've got any other comments than what I've put through about that evaluation, so that we make sure that we use everything that's in that report to improve our engagement. But thank you very, very much, all of you. Good luck. And thank you, the work you've done. It looks like, touch wood, touch everything, that we might have escaped another outbreak due to the fantastic response from people. Thank you.
Absolutely. Thank you. And thank you for agreeing to continue to be a part of this conversation with us. Wonderful.
Thanks all.
Thanks so much, Dr. Young. A big rounds of applause and waves.
Bye.
Lots of waves. So I'm just going to introduce two people now, because first we're going to hear from Sarah Youssef. Now, Sarah is a Mater refugee health consultant. She's one of the group of 11, the G11 that many of you will have heard of, the refugee health consultants managed by Mater Refugee Health. She's originally from Iraq and works closely with the Arabic-speaking communities in Queensland. And we're going to see just a short video from her, really reflecting on those early days and the way that community members and community leaders just sort of stepped into that space and were sharing and trying to be involved in that sharing of communication that we know is critical in a situation like this. And then straight after we've seen that video of Sarah, Bridget Abel will be joining us. And Bridget is the research fellow from Implementation Science from the Australian Centre for Health Services Innovation at QUT, School of Public Health and Social Work, Faculty of Health. And she's really going to present us with the findings from the report, which I'm sure will cover off on some of those pieces that that really sort of spoke and stood out to Dr. Young, but all of the other sort of pieces that we're seeing coming from this piece of research and this, this part of the conversation that we're all having about this. So first we're going to see a short video from Sarah, and then we'll hear from Bridget herself. Thanks. And technology will work with us on this.
Hopefully. All right, hopefully you should be able to see a video.
So during COVID-19, when COVID-19 started, it was very hard to all of us, to the community as well. So we tried so hard to spread the information to a big amount of the community. So my best option was, we did a group on Facebook, and that Facebook group was 800 plus people was there. And also I did some connection with the lady who makes the cakes in the community, for the hairdresser lady, because they got the contact number for many of the families who I can't really reach, and messages were spreaded very easily between them, which is great. The challenges was with the old people, they don't have access to social media. Most of these messages come through Facebook and WhatsApp group and Twitter, and that was really hard at the beginning when we first started. However, for us as a trusted member, work with Mata, we post these messages to the priest and to imam, so they have most of the contact number for the community, and messages start to be passed. And also they knew the vulnerable people, who they really old, who they really needs help. So those messages was going directly to them from the priest, of course. And if we have the numbers, I did myself a few of the old people who making sure give them the right information that they need. So that was a lot of confusion from the information. So we're passing the information being translated from Queensland Health. However, they heard a lot of information from overseas or from other states, and they got confused which information is the right. So we always encourage them, as long as this information coming from Queensland Health, that's mean what been happening in Queensland. So we all need to follow this information. It's related to state where you live in. So whatever you heard from overseas or different states is completely different rules. So that was the main thing. Always we encourage them to trust the messages coming from Queensland Health. That's why in every single message, we always at the beginning, when we record any messages, we will start it like, this is my name is Sarah, I'm from the G11 group, we work for Queensland Health or from the Mata Hospital. That's from the beginning. That's how is the key to trusted from the community. What does it really make it work? During the whole years working with Mata and be a member of G11, that trust make it really easier for us to post these messages. This resource is actually trusted. So whatever I said, whatever I pass information, I say this is coming from Mata Hospital, this is what we've been discussing, this is what we're having through Queensland Health, it's all being trusted. So that's make it so much easier for us.
So thanks to Sarah for recording that message, and I'm sure you'll see many of the things she's been talking about when I go through the evaluation of the report. So I'd just like to share that with you now. So my name's Dr. Bridget Abel, and as I'm a research fellow in implementation science at OSHI at QUT. And really my role was to work out how we were going to evaluate this response. So I wasn't involved with the initial stages of the partnership, but I did come in the middle of last year to work with the team to really look at the impact of this and how could we actually have something tangible around all these things that they thought were making an impact. And so, as Brooke said, it was really driven by Brisbane South PHN, Mata Refugee Health and Metro South, working with us to conduct an evaluation. And it was really looking at the impact within the community, but also I was interested, and they were also interested in looking at that partnership approach. And was that partnership approach an effective way to drive this engagement? And really this all focused on those early stages of the pandemic. So as Dr. Young was saying, things have gotten better, things have changed, but really this was that really early days and what was the impact in that crucial time. So the real aim of the evaluation was to see how effective the project had been in meeting its aims of providing that timely, accurate and appropriate information to the communities. And really this was, we decided to look at this in terms of 3 questions. First, there was the effectiveness of those strategies which were used, that, simple translations and the audio visual, was that meeting the needs of the community? And secondly, what was the impact of engaging those community leaders, of having those intermediaries? What impact did that have on the project? And then finally, as I've said before, what was the impact of having this partnership driving all of that? And so that's how I'll discuss the evaluation today. So how did we actually do this? Well, it was actually a really interesting process. It was a completely co-designed and co-conducted evaluation between multiple stakeholders. So you can see this is me here with a little green box, and this is our wonderful project partners. And so we all met in a virtual workshop to work out how we wanted to evaluate, what types of questions, and what sort of format this would take. And that was a really wonderful experience. And then I was able to take that information and map it to an established evaluation framework called the RE-AIM framework, which is great because it allows us to look at things like reach, which is what was really key with this project, effectiveness, adoption by particular communities, and implementation and maintenance over time. And this was a really wonderful structure to have. And then I was able to take that back to the partnership in another workshop, and we could work through those questions and how this was going to happen and how data would be collected. And it was actually a really wonderful, wonderful evaluation, because all of the data collection was done by the community members, leaders, bicultural staff, the project team. I didn't do any data collection at all. It was all done pragmatically in the native language of participants, 90 different community members and leaders, using things like interviews and phone calls and focus groups and surveys, as well as just some simple like social media analytics and things like that. And it was a really, really wonderful approach to evaluation. And so, as I said, we looked at it from those 3 different levels. So I just was going to step through those now. If anyone's interested in how we did do the evaluation and the methods around that, I'm happy to chat to you separately about that. But in terms of our findings, I'll run through those now because I think they're really interesting. So we managed to speak with 51 different community members, and we were really interested with them in looking, as we've said, about the reach, how far did this information go out and why or why didn't it get to the communities it was supposed to? And then what impact did that have on people within the community? So first of all, what did these communities look like? What was the reach of the project? And as you can see, it was really diverse. So there was 21 different ethnic, faith, or refugee groups, and they spoke 28 different languages. And this is really, really fascinating, being able to look at the reach and effectiveness of the partnership. And you could see it was really varied and diverse in terms of what was there, and some very, small groups, and then some much larger ones as well. So, key question, how were people actually getting information during the pandemic? And really, it was from multiple sources. But really, it was most often coming from within their own community, including also social media and WhatsApp groups. So the number 1 place that was listed most often was CALD community members and leaders. That could have been family or friends, but was most often those faith leaders or community members. And social media might have been from overseas, but it was mostly those local community-led WhatsApp groups driving that. And they did still access information from Queensland Health and from the press conferences that Dr. Young held. And then it was those overseas sources and other sites that were less sought for health information. So really, choosing to target information through our CALD leaders really was an effective way, of reaching these communities, and probably the preferred way of reaching these communities. So that was really encouraging to see in terms of the results. Now, interestingly, is the idea of trust. And we heard Sarah talk about trust. And, trust is really key, especially because some of the research says that having trust in government authorities and in health authorities is really key in terms of being able to take up a vaccine. Communities with high trust are more likely to take up a vaccine. And it's really interesting to see, which may be counterintuitive to some people I've spoken to about this, but when we asked people, who did you trust the most? The number 1 answer was the Queensland government, and specifically naming Dr. Young and also the Premier. People really felt that they were experts, they were reliable, they would give them the right information. And then secondly, they did really trust those leaders as well, because they sort of embodied them, they represented them, they communicated in a way they understand, and they took that official information and gave it to them in a manner that they could more easily access. So, by engaging our leaders in this process with the Queensland government and Queensland Health, that's probably the most effective way to build that trust and to have that trusting relationship. Besides this, we also wanted to know whether information was actually available, whether people could access it. And, most community members could access some type of information, whether that was an official translation through Queensland Health or one of these adapted versions that community leaders shared within their own communities. The problems, as we've sort of heard already with those official translations, was the quality. It was a really variable quality, some lacked linguistic sensitivity, And particularly in that early pandemic period, the speed of release was just too slow to meet the needs. People did like them though, because they could then take those and translate them themselves. Or some people liked to, if they had translations that weren't so great, could refer back to written original documents and pass them on. But really, people did find the audio and visual versions much easier to understand and share on social media. So there was that need to have both, have all different types of formats available to people to meet their needs. Unfortunately, there were still some languages that didn't have any information, particularly the Chin languages. So there is more work to be done. It never ends. There's plenty more to be done in terms of this. And I guess, with all of this, the key question is, well, was information sharing actually meeting your needs? Could you find what you needed when? And really, within this project and within the scope of this project, it did seem like, the majority of people were having their needs met. Obviously, it wasn't the case for everybody, but, that's quite a large proportion of people who felt that they were being heard and met. So within this group that didn't have their needs met, it was mainly because they were, say, unable to read and couldn't have audio translations, or they didn't just have any translation available in their language. They had a written translation, but they couldn't understand it. So hence more need for that audio translation or that one-on-one, potentially phone call, and that the delays that we heard about, the delays impacting how they felt in that moment and what they could do. So these are things we can definitely work on heading into the future. And so finally, with our communities, we wanted to see how they experienced this. What were the challenges? What were the supports that helped them access information? Were those leaders acting as the supports we thought they should have been? Was, this a really effective strategy? And the challenges, we've heard about the challenges already. The, difficulty understanding English, key challenge. And when there's no translated resources to help you, it becomes even more of a challenge. That information overload, conflicting information, and confusion. Confusion was a word that kept coming up again and again. And, I'm sure all of us, whether or not we came from these communities, experience this information overload, and just think how much, more difficult that would be, having those other barriers and challenges in the way as well. And as we've said already, that fake news, conspiracy theories, and misinformation really drove fear and uncertainty in the community. And so there's a need to really tackle that if we can in the future. Fantastically, the number one support that people said was having those community groups and leaders there for them to translate, simplify, and share information with them. Okay, having plain language translations in multiple formats, and having social media to have information pushed out to you and not have to search for it, and to have it make sense to you, but also to have a two-way platform to engage with leaders and ask them questions was really seen as key. And then that regular information sharing, as we've seen today, that real engagement from our government and health with the broader Queensland population, but also specifically with these communities was really appreciated. So that was our community members, which is, some things to work on, but generally a really positive impact in terms of reach of this project. So then we also wanted to look, I guess, at the next level up at those community leaders, and what was this like for them? What was it being a part of this unique approach to community engagement and sharing? And so we spoke to 39 different leaders and really wanted to look at the reach through them, the adoption of them and their communities of this type of approach, and then the impact that had within the community as well. So once again, a very varied group of leaders involved. Now this was formal leaders, formal leadership roles, but also those who were just seen as leaders, informal leaders within their community. And you can see there's an even broader scope of groups and languages here. Some overlap with the community members, but then some extra languages and groups as well. So we know how our community members were accessing this information. We knew they were getting it from the community leaders, but how did that happen? And as you can see, it happened across multiple platforms, different mediums, different approaches. It really was a very, very brilliant exercise by the community leaders in reach. So you can see primarily social media, as we've already heard, is key. Those WhatsApp groups was a major method of sharing information, Zoom as well, but really just phone calls. Phone seemed to be a really big driver, particularly in some of the communities, and text messages. People really liked the fact that they shared personalized text messages. But you can see it was a wider variety, and some of this did happen in person when restrictions eased, through those faith groups and congregations, as Sarah mentioned. I think the really interesting thing is that when we asked leaders about their reach, they guessed they, on average, they'd reached almost 200 community members. And that's really amazing. For some, it might have been 10, for others, it was 1,000. But on average, to reach that many community members shows the benefit of engaging just one of these community leaders. And, there was the example of Quack, who we heard about earlier, where they actually reached 30 different language groups with their translations and probably thousands, tens of thousands of community members. So by engaging the right people, you can reach a broad amount of community members. And really this quote from a leader just typifies what it was like for these leaders and what they did. So I received translated information via MARTA G11 or Queensland Health, and then I pass it on via social media. I put the information in our Viber group, I shared some translated documents via text or WhatsApp, and we made audios of the written information. So it was a lot of work that these leaders did, and they just seemed to have a very good reach of their information. But the one thing that did come out very clearly was they couldn't just share what was there. They couldn't just share a resource from Queensland Health. Really, a lot of the time, they had to just translate the key messages that they were able to access and simplify these into everyday language and create those text, graphic, video, or audio versions. But then they also had to tailor how they shared that information. As Dr. Young was hinting at, it's not just putting it up on a website. They tailored the delivery to the recipient. If somebody wasn't able to read, they made sure they had an audio version. If somebody couldn't access the internet, they made sure they called them on the phone. And really, they used names in text messages and things like that. And they even used their own experiences of maybe going to get a test or getting a vaccination to encourage their community as well. So like the community members, we were interested in the challenges that were involved for the leaders being engaged in this project. And actually, they were very similar challenges to the community members. So for leaders, having a lack of translated resources really hampered them. They had to go and find English versions and translate them. It just slowed everything down. They too experienced information overload and misinformation, and it really made them feel like, well, how can they trust me? How can my community trust me if I don't know what to believe? And they had this idea of fighting the other noise of social media and overseas information and how challenging that was. And really for the leaders, trying to get beyond the digital divide of no access to technology and having to call people or speak to them face-to-face was also a challenge, but probably a necessary process to reaching some of those community members. Thankfully, they also had supports. So social media, despite not working for everyone, was really a key support for information sharing. And as Sarah talked about as well, having those existing networks and relationships, there was already trust there and they could capitalize on that to share information with their community. They too liked having support from the government and authorities, special leader forums, and the simple visual messaging, if it was available, was much easier for them as well. Then finally, with our leaders, we wanted to know, well, what was that experience like? Was it a good experience for them? Would they do it again? And really, they did talk about significant challenges, but most did feel satisfied. They felt engaged and they felt supported. They talked about things like the online forums and WhatsApp groups and that constant communication with health services and their own partnership organizations. And really the key thing that came out was they liked working collectively because they could learn from each other and they could share. And it built this sense of community and the fact that they were involved in this process and not just being spoken to. So finally, we come to the Interagency Partnership itself. And, is this partnership approach something that could be used somewhere else? Is it something that will work equally as well for another disaster, another pandemic? And how could it be continued if so? So this part of the evaluation was purely done with all those partners that were brought into the partnership over the course of the pandemic, using a tool, a survey tool, which asked partners about, what they thought of the partnership. And really, across the 7 different domains, when they were added up, it really did demonstrate that a genuine collaborative partnership had been established, which was really fantastic, given, the way this happened wasn't necessarily planned, out beforehand all of the time. And particularly in terms of determining the need for the partnership, there really was unanimous agreement that there was a need for the partnership, and that outweighed the cost that might be involved of that partnership. There was investment, there was people committed, and there was a need to continue it into the future. So this partnership approach seems like a really great way to really tackle this problem and engage with community. In terms of the partnership experience, and the greatest by far challenge was the time and labor intensive nature of collaboration. And that was really difficult for people. But, you know, they looked beyond that because of the supports and the benefits. You know, those pre-existing relationships that many of the partners had, they hadn't all worked together, but they gradually came together, and there was an immediate level of trust. So they could hit the ground running and just get on with this project. They all had commitment, they all had a shared goal and motivation, and being able to meet virtually really provided equity within the partnership. So not just, you know, it wasn't equity beyond the partnership for these communities, but equity within the partnership as well. And because of that, you know, the partnership participants were really satisfied with being a part of this. You know, 85% satisfaction level of people of being a part of this process, which is wonderful. So it's such a, you know, such a positive thing that should probably be capitalized on and strengthened. And while partners did feel confident in doing that, there was a couple of key things that needed to be addressed for moving forward. And that's that there was needed to be more efforts to engage and enable CALD community voice centrally within the partnership. And then secondly, because this did happen sort of organically and at speed, there needed to be a bit more formalization around this partnership moving forward and how that worked to really continue it successfully moving forward. So I guess, finish up, I'm going to reiterate some of what Dr. Young has already said. What can we learn from this about communicating and engaging with our communities in the future? Firstly, it's about translations, improving translations. We need more translations, we need more simple translations, and they need to be available in a range of formats. Those plain English translations need to come from trusted sources, and they need to get out there as quickly as possible. And then finally, really, so much of this work was done by informal translations by community leaders who just did it. They weren't accredited translators, they just did it themselves. And it was so integral to the reach of this into the community. And so if there was a way to support that more formally in the future, that would definitely help with the sustainability and the reach of this type of work. The other key recommendation is really around that authentic community engagement. And so engagement of more leaders, more members, particularly in those smaller communities where there may be no formally accredited translator, and you need to get into those communities with your information. And as part of this, health services really need to invest in training, remuneration, and support. That was loud and clear from the leaders. I didn't touch on it before, but they just need support. This was all done voluntarily, almost all done voluntarily, and they just need some support to continue doing that and doing it effectively. And so for that, health services really need to develop partnerships and work out where that time and money might need to be invested. And really, that's a process that needs to be built and maintained ahead of time. We need to do it now for the next pandemic, for the next disaster, so we can really build and earn that trust. So I guess closing, I mean, it does really show that there are benefits to this collective response with reciprocal education between communities and health and our broader population. And there really was a clear impetus to continue this approach into the future. And there's other work going on in Victoria and New South Wales that's saying similar things to this. So I mean, it's likely that the recommendations here, the findings here, they probably do apply to engaging CALD communities across the rest of Australia. So if you are interested in the report, I know you'll be being sent a copy of it after this. We also have a summary, and you can contact me about any information related to the report by email. But I do thank all of the project partners and our evaluation partners as well. Thank you, everybody.
Thank you so much, Dr. Bridget. And thank you so much for accompanying us through that whole process from last year. And yeah, as Bridget said, you will be sent a copy, a link to the report. And I know that for many of us, there'll be things that really resonate with the work that we do and the experiences that we've had. I'm now going to ask the lovely Donata Saki from the MARTA. Donata is the director of MARTA Refugee Health Service and is the chair of the Refugee Health Partnership Advisory Group in Queensland. And she's just going to do a little bit of a reflection of kind of what's come through from her and how this kind of keeps carrying us forward. Thanks, Donata.
Thank you, Kerry, and thank you, Bridget, and thank you everyone today for the speeches. And it is a little bit of a reflection on my part, and hopefully what I'll try and do over the next couple of minutes is just to embed some seeds of how we can actually carry this work forward. But before we begin, I also would like to acknowledge the traditional owners of the land that we stand on here today in South Brisbane, the Yagara and the Turrbal people and their leaders past, present and emerging. And I know that they've cared and nurtured for this land, and it always was and always will be Aboriginal land. So in the past 18 months, it's been very confusing, it's been challenging, but we've also opened up some opportunities to collaborate and do things differently. Of course, COVID has plummeted the globe into a state of chaos and anxiety, which has disrupted the way we live. But I would like to conclude the launch today by looking at how the learnings from this evaluation have been implemented with a focus on the CALD COVID-19 Health Engagement Project. And secondly, more broadly, how do we actually ensure that we sustain these learnings into all aspects of policy and practice? And are we ready for the next challenge, as Bridget was referring to? This report really reflects the importance of engaging communities and nurturing the networks in order to activate a collaborative and effective response to COVID. The essential nature of any network is not hierarchical, but rather the strength of a network is the shared purpose and meaning amongst its members. As mentioned today, it was the pre-existing networks, partnerships and community relationships that facilitated a response. People came together not because they were directed to, but because they saw value and purpose. The process was equally important to the outcome. Hence, when Queensland Health's funding became available to strengthen the engagement work, the partners were careful to remain focused on the learnings from the initial collective response. In particular, as a community development-driven response, attention to building trust, sharing information, discussing priorities and project structures, including the remuneration of the community leaders and members, was and is critical. In less than 12 months since the CALD COVID-19 Health Engagement Project started, and I would like to acknowledge the hard work of the project team, Grace and Faisal, who alongside the communities, the project steering group and the reference groups are trying hard to implement the learnings from the evaluation. In my assessment and reflection on how the project is implementing the learnings, I would like to highlight three key things. Firstly, the creation of plain English messages, translating information using various modalities and disseminating this through a community-driven platform is the heart of the project. The collaboration with Queensland Health and through the social policy branch to undertake this work has been amplified and great outcomes achieved. Equally important has been the collective insight that we don't have all the answers, that there are still gaps, and that an iterative process which values an ongoing dialogue with the communities is needed. We don't know what we don't know, and overstating our capacities or our reach is also detrimental to trust. The project is trying to embed a community development approach that privileges the knowledge and the wisdom of communities and also builds the capacity of our government entities, our communication and strategy experts, our clinicians, our researchers, and our policymakers. Secondly, the core community leaders and key community members who are influential in their communities are critically important. However, it is a challenge to create real space for diverse voices to be heard. Feedback from those interviewed in the evaluation consistently acknowledged the importance of leaders who stepped up to close the gap for their communities in accessing information. As predominantly volunteers, like we've heard, who care about their communities and want to help, they do a great job, but it is not sustainable, especially in the relentlessness of COVID and continuing demands to share information, whether a new direction or about the vaccine. Access to Queensland Health resources to fund community leaders is a key part of the project. We're also looking at different ways to embed mechanisms to remunerate community volunteers so that their participation is valued and sustainable. Similar to the G11 model, nurturing community consultants who act as a bridge between their communities and their health systems requires resourcing, time, and engagement. Remunerating our active community partners requires both a philosophical and ethical shift. As a start, it is good that political leaders and those in position of power have acknowledged the role of community leaders and the work they do in their communities. However, we do need to move beyond this acknowledgement and create sustainable change to the way we think about communities. The philosophical shift is not about asking communities what we want to know, but asking communities what is it they want. Core communities hold their own solutions, but in a society where we don't really have great diversity at senior leadership level, and we need to acknowledge that this limits the strategies and solutions government and organisations can come up with. Hence, to work with communities does mean a sharing of power and resources. The project is grappling with this, which is a good thing because it means we're collectively working out what will make a difference to community partners to enable their participation. And thirdly, the last reflection is on the partnership with key stakeholders across government in areas like comms and strategy, disaster management, task forces and advisory structures. It has been equally challenging and rewarding to work alongside structures that traditionally may not have actively thought about core community engagement and how to embed this in their usual practice. Whilst we still have work to do in this space, the project is acting as a boundary spanner across government, non-government and communities. The additional time and effort is reflected in some of the project resources like the vaccine information slide deck, which is still evolving and is a great example of communities identifying the issues and working with government to provide appropriate responses. I would like to challenge everyone who has an interest, a role to play, whether through their communities, professional roles in government, policy, politics, to really ponder on how space is created to enable diverse voices, not just to be heard, but to be part of the solution, the strategies that inform practice, the things that matter. This evaluation is a collective reflection on how and why we did what we did, but now we're trying to embed the evidence to give decision makers the confidence to spend public dollars or redirect resources because they have the conviction that it is good, sustainable and ethical practice. It is good and ethical practice to not leave anyone behind, to ensure access to information and services, and to build culturally and to be culturally and linguistically appropriate. This holds true not just during COVID, but it was throughout COVID that some of the urgency and focus on the above points have occurred. The project is looking at the long term and in partnership with all the stakeholders, including with the MAQ-funded Community Connector role based in the Red Cross, is looking at making a difference to how we plan and respond to the inevitable future challenges. We can't go back to old frameworks. Policy moving forward can and should incorporate the learnings from this evaluation. The project is a good start as an example of how we put this into practice. It is only a start, and hence it is great to continue to work with Bridget and her team to reflect on our practice. I'm hoping that the way we frame policies and prioritise work will be informed by this evaluation so that we don't limit the creativity and power of the diversity of voices. The pragmatist in me is still well aware that government and organisations often want and need quick and efficient fixes that maximise return on investment. The return on investment, which has been made somewhat visible by this report, has been the slow-burning investment to build trust with communities, to enable opportunities to resource and employ and work alongside. The optimist in me is hoping that we have learned from COVID and that the core COVID-19 Health Engagement Project will be a template to build from, that we continue to value and remunerate community leaders and anyone who's stepping up to take leadership to support their communities, that we continue to work hard to privilege alternative views and knowledge, and lastly, that the boundary spanning work across communities, government and organisations is valued and sustained. Thank you very much.
What more can you say? Thank you so much, Donata. That was a brilliant clarion call, I think, a real challenge to all of us. The reason that we wanted to gather together with you today and share this research is because it has been such a critical question for us to share with each other and most importantly with our partners in community. And all of those questions that come up that are the challenges that we face, but the opportunities that are presented through them, the opportunities to think differently, to think creatively. So we invite you to continue to be a part of this conversation going forward, to looking at where this is one of those opportunities for us to say business as usual wasn't so great. Moving through COVID where we are now, let's see what we've learned and do things differently into the very near future and beyond. Thank you so much, everyone, for being here today. Thank you so much to all of the speakers. Thank you particularly to Sarah Youssef, who came to us on video link because she's imminently about to have a baby, and so wonderful for her to be in the space with us and share that voice from community as well. We're leaving. Please feel free as you finish off to put comments into chat and put questions into chat. Dr. Jeanette made herself available. You will be sent a copy of the report. Please go through it like Dr. Young did. And thanks again to everyone. Hopefully I haven't missed anyone. But yeah, we are keen to keep this conversation open in this space because of the implications it has, not just in the health space, but beyond. Thank you. Thanks so much to everyone. Come off mute and say goodbye.